Ria Blakey. I'm the Associate Director for External Outreach and Engagement at the FDA Oncology Center of Excellence. And I welcome you to this edition of Conversations on Cancer. Today, our subject is Eliminate the Gap, addressing cancer disparities in the U.S. Latinx LGBTQ+ community. And yes, we're talking about the intersection of those two communities. Recently, it's been known that there are approximately 1 million cancer survivors who identify as sexual minority LGBTQ cancer survivors. And so what we'd like to do is really get a sense of where the gaps exist during this program. And also, before we conclude in the next hour, to talk about opportunities for bridging those gaps, for reducing the cancer disparities in the Latinx LGBTQ community. So thank you for joining us. We greatly appreciate you being in the audience today. And I would be remiss if I didn't give our director, Dr. Richard Pazder, an opportunity to give an official welcome, because Conversations on Cancer only exists because he came up with the idea. He thought it was very important for people to talk about these issues in somewhat of a non-formal setting, but still to get at the root of social issues that impact us all. So Dr. Pazder?
Well, thank you so much, Ria. The Oncology Center of Excellence is the newest center at the FDA and started about 5 years ago. The concept of it is really to coordinate the oncology activities across the various areas of the FDA. And part of our major goal is outreach, and Project Community, which Ria heads, is really the forefront of that outreach facility to various areas in the United States and worldwide. I always stated that many times at the FDA, we get concentrated on what goes on within the Beltway or on the East Coast, so to speak, from Boston to Raleigh, Durham. But there's a whole other country out there, so to speak, and we got to let people know what the FDA does because they're our most important stakeholders. So this whole concept of these conversations has evolved around getting out the issues that we deal with here at the FDA. Obviously, we have Project Equity within the FDA, which addresses the diversity issues. And this is part and parcel of that discussion of looking at diversity in clinical trials, medical care, particularly oncology care, since we're the Oncology Center of Excellence in the underserved and underrepresented areas. So I'll leave it at that. And I'm looking forward to this conversation. I was really fascinated by the topic. It looks like this concept of this intersection of two groups is going to be a really interesting discussion. So I'll shut up and listen. Okay.
Please don't shut up, because we do want you to continue to participate in the conversation, but we do want to make sure that our panelists have an opportunity to introduce themselves and talk a little bit about why they're joining this panel. And so, Loriana, let's start with you. Give us about 30 seconds of who you are and what you bring to this panel discussion today.
Well, first of all, it's such an honor to be here with all of you today. My name is Loriana Hernandez Aldama. I'm a 2-time cancer survivor, leukemia and breast cancer. I wear it like a badge of honor. I was a former news anchor, medical reporter turned cancer survivor at the time of my diagnosis. And now with my nonprofit, Arm Up for Life, our platform really is about amplifying the patient voice, being Latina, about amplifying and focusing on the brown and Black community as well, and the underserved communities like the LGBTQ communities, and looking at how we can focus on not just risk reduction, but also improving the patient experience and talking to patients and building that trust. Because I keep saying we cannot just build trust in silos. It has to be a whole package. So thank you for having me on the panel. I look forward to a very lively discussion.
Thank you for being here. And also our special thanks to Dr. Mark Puccinelli, who is pitch hitting. We had another panelist scheduled. Life got in the way. And we're hopeful that all is well on the other end for the other individual. But we're really thankful to have Mark here as well. So Mark, why don't you tell us a little bit about yourself and what you bring to the panel?
I'm very pleased to be here and I'm excited about this panel. I'm an associate scientist at the University of Miami in the Health Promotion and Care Lab. Most of my work has up to this point been in HIV prevention, but more recently I've been pilot testing and developed an intervention for sexual minority men who have HIV and cancer. And so we're rolling that out now. And so that I think is my connection more to the panel today. And I'm also in South Florida in Miami, obviously. So the Latinx tie-in and the importance of culture in everything we do as far as research goes is really important too. So my pleasure to be here.
Thank you. And joining us from Puerto Rico, Olga, say hello to the folks.
Hello to everyone, hola. And yes, my connection to the panel is I am part of the LGBTQ community and I am Latinx as well. So I just kind of represent that area. I am a cancer survivor, breast cancer survivor, and mainly interested in speaking to you and letting you know in the panel about what patient thinks and when they know and understand when they receive a diagnosis of when they think they have the disease and taking charge and control on that, right? So how does that play into when you as a patient thinks you need to go a route and doctors might think differently, and then what do you have access to if you decide to go your route instead of what the doctor says? So that's one part. But also as an advocate of the community, of the LGBT community, is understanding what it is out there in terms of our transgender people community, and even the non-binary community that they don't identify when they as a woman and men, but then therapies and hormones and the transitions processes they go through. How do they have a picture into the development of some type of cancer or even the risk that they might have because they go through those therapies to be themselves. And then honored to be sharing with you just my story.
Thank you. Thank you so much for joining. Also, Michelle Veras, who is with the National LGBTQ Cancer Network. Hi, Michelle.
Hi, Ria. Thank you all for having me. I'm really honored to be a part of the panel today. So as Ria mentioned, my name is Michelle Veras, and I'm the projects director at the National LGBT Cancer Network. And as a queer Latina, cancer is something that is really a focus of my work, looking at the intersection of these two identities. So I'm excited to share with you all today some findings that we looked into from a national cancer survivor survey that we conducted last year. So again, super excited to be here and discuss these issues today.
Thank you. And Dr. Karen Winkfield, who by a lot of standards really doesn't require an introduction, but for those of you who are not familiar with all of the fabulous work that she's been doing truly in cancer disparities for many years, and a recent appointment to the National Cancer Advisory Board by President Biden. Welcome, Dr. Karen Winkfield.
Thank you so much, Ria. I really appreciate it. And thanks to the FDA. Thank you, Dr. Pazder, for opening up this forum so that we can educate others about some of these issues that are critically important in terms of ways that we can actually make sure that everyone has the same opportunity to survive cancer and to survive it well. And so I am a radiation oncologist, but my current job is actually as the executive director of the Meharry Vanderbilt Alliance. That's a strategic partnership that's really focused on how do we engage communities to really improve health and well-being. And I tell you, it's been something I've been doing for a very long time, as you've alluded to. I am a community engagement expert, but I'm also an implementation scientist. And what that means is my focus is not on how do we describe the problems, because we've known that the problems have existed. But to your point, we want to talk solutions. And so I'm a program builder. I build programs. I really like to think about what are the ways that we can improve care for everyone, and particularly those populations that have been so underserved, disenfranchised, and frankly excluded for so long. So I'm so grateful to be on this panel with these amazing folks. I'm so glad that we have Michelle here. I can't wait to see that data. So thank you so much for being here for everyone on the panel.
Wonderful. Now, I've encouraged everyone not to be bashful, but let's just kick off with Michelle and the data since we're all interested to hear some of the results. So Michelle, would you share, please?
Absolutely. And so I'll start by just kind of giving a brief overview of the survey. So the National LGBT Cancer Network first conducted a small survey of queer cancer survivors probably about 5 years ago. And so we for a long time have wanted to do a follow-up on that survey to recruit more participants and also to recruit a more diverse participant base. So believe it or not, in the midst of COVID, we launched a national survey of LGBTQIA identified survivors. The survey was entirely online. We did recruitment via social media and also some paid media campaigns. I think that there's such a gap in research when we look at the intersection of these identities. So, okay, there may be research on the Latinx community, there may be research on the queer community, but what about folks living at the intersection of these identities? So I will say that our participants that identified at that intersection was fairly small. It was about 6% of those 2,700 participants. But really, broadly, what that information showed is that anyone living at the intersection of being a member of the queer community and then also a racial ethnic minority generally had poorer experiences in their cancer care. They were more likely to have delayed screenings to begin with, so less likely to receive scheduled cancer screenings even before their diagnosis. So we really just see lots of gaps, not only sort of when people enter care, but also then moving on through survivorship. I'll also say that the full results of that survey are available online on our website.
Thank you. And I'm wondering, Olga, does this sound at all familiar? Based on your experience, did you find the idea of having access to screening and just having information in general perhaps a little bit more challenging than others?
Well, in my experience in Puerto Rico, we are all Latin, so it's you won't see it from the Latin perspective, but more from the LGBTQ perspective, where just the simple fact that if you are on the closet, like we call it, you feel afraid to go to certain doctors to go and do your checkup, right? Because you don't feel identify as a woman. Let's have the example. So you struggle going to a gynecologist to go and do your checkups and your routinely medical workout. So that not having the right environment to be yourself impacts. Then if you actually go, then it is different. That trust that you build with the doctor, where you should feel free to say who you are and how you feel, then it comes to the fact. So if you get to the doctor, then that's one aspect that we experience. Am I going to be judged because of who I am? Am I going to have a discharge rapidly because the doctor cannot deal with who I am? So those are things that I've talked to other to fellow friends or members of the community, not personally to me. I have to say that for me, I had within the situation of being diagnosed with the disease. Beyond that, I had a good experience on my journey. But that's why I advocate now, because not everyone that I know has had that aspect. So
and I was going to add to that doctors tend to. Not all of them, but I'm saying somewhere we need to focus some education is not having assumptions about your patient, about whether he or she can make it to appointments, whether that person with your patient is their spouse or their sister or their brother or whomever it is, that there needs to be that dialogue to remove the barrier and the intimidation. Even going through my own cancer treatment, talking about sexuality and intimacy, it was like, la, 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 we're not going to talk about that. And I'm saying, but what if I survive, which I hope I do, I want to have a relationship with my husband. And in that case, intimacy, sexual relations, how you identify is almost, I found, and what I hear from people reaching out to our nonprofit, almost taboo. So a lot of what I talk about is that as I hear funding being allocated from so many pharmaceutical companies, and I'm so grateful for that, and we're making so much progress, we need to strategize how we allocate that funding and realize we can't just build trust in silos just with diversity in clinical trials. We need to build trust from the point of entry, from the point of meeting the patient, all the way through the process where you're going to lose them. And as Olga said, once you lose them, you delay screenings. When you delay screenings, you catch cancer at a later rate, and it just snowballs.
Exactly.
Dr. Wingfield, did you want to weigh in on that?
Oh, I do. So it's so important. Everything that was said, I want to go back to one of the things that Michelle talked about, the lack of data. In our electronic health records, which, look, we have come leaps and bounds with the way that we actually capture data related to health experiences and exposures. But we don't oftentimes capture data on sexual orientation and gender identity. So frankly, we don't have all of the information. We don't know how deep the disparities truly are because we have to kind of live in a vacuum. There's not enough funding to do the research that we need to do to say, hey, what's really happening with this particular population, this intersectional group? And yet we don't even have the culture of humility. And that's the term I'm going to use. People will throw out cultural competence all the time. And I tell people, you will never be competent in my experience as a Black woman. Never, right? What I need for you to do is, as a provider, have humility and say, tell me about your life. Tell me about who you are. Every time a patient comes in front of you as a provider, stop and say, how would I want my family member to be treated, right? And if that doesn't work for you, then treat them the way that people deserve. I mean, this is not rocket science, just asking. Don't make an assumption that that's somebody's sister. Say, who's with you today? Don't make an assumption that that's somebody's husband. Could be their boyfriend. Like what? So part of it is to what Loriana was talking about too. Just rethinking the practice of medicine. And doing it not just from the physician standpoint, but every single team member, and making sure that there's awareness about the importance of being inclusive in the way that we approach communities. And of course, the approach does not begin when they walk through the door. It begins way before that. We don't want to be engaging communities once they have cancer diagnosis. We're seeing that now with COVID, right? We don't have a public health strategy in this country, and we need to have one. And that's really come to the fore with the COVID pandemic. But those of us who have been in this space doing disparities research will tell you we've been doing this for decades, saying how can we engage communities better, but we need to have the infrastructure. And this is where planning grants and opportunities in terms of funding will come into play. How do we make sure that we're leveraging the capacity that is existing in each of these communities and leveraging them to help do the engagement work?
And I don't know, Mark, if any of your past work speaks to the conversation thus far, since you have straddled HIV and cancer.
Yeah, I mean, a lot of different important points to follow up on. One, I think that Michelle had mentioned about the research and our basis for making decisions and sort of planning how to address these disparities going forward. And historically, the research has been really limited in part because sexual minority status has not been included as part of the medical record. So looking back even just a few years, trying to tease out, what are these disparities among Latinx sexual minority cancer survivors is really difficult. People have had to put those data together by looking at HIV registries and trying to extrapolate what the overlap is. I think maybe more recently that has been included, but I mean, just from a policy perspective or just a medical records perspective, including all of that information will help us going forward, and also maybe inform the providers as well to keep that in mind and not make those assumptions like Dr. Wingfield was talking about when they do see their patients. So that is just one thing that jumped out at me from the conversation.
And I just want to add to something that Dr. Wingfield mentioned. I think, this really is a two-pronged approach, right? Like it's making sure that our systems are set up to collect this data. So making sure that it's included in electronic health records, but then also training anyone who comes into contact with the patient about how to ask these questions. We were having a conversation at my organization earlier about like, okay, yes, just turn the switch on in the EHR, but why isn't it that simple? It's because you have the person at the front desk who's like, I don't want to offend my perhaps more conservative older patient by asking this question. Or like, well, I don't really think that's important, so I'm not going to ask it. So it really, like, that second component of doing the training and education is just so critical.
I also, if I could just add one more thing, we were talking about the maybe unaffirming or stigmatizing interactions with providers. And we see that in the research too, that even one or two negative interactions with providers who are maybe stigmatizing can lower the likelihood that somebody will get that follow-up appointment or who will voluntarily go for screening. And so we see that leading to poor delayed care, poor outcomes, and poor health-related quality of life too. So even those single encounters are really important. And I think provider training is a hugely important area to focus on going forward.
Do you think also that the healthcare providers themselves feel uncomfortable about the topic inherently in themselves? You mentioned that they feel that they may offend somebody, but in their own sense, they feel, this is difficult to talk about. And here again, this is an area that is not taught in medical school or nursing school. And I think that the issue here is really to address these issues very early on in medical education, whether it's nursing, physicians, healthcare providers in general. But this is an area that's totally ignored, so to speak, of how to address this issue. It's almost a taboo topic to get into.
And I agree with that education is so important to reduce the stigma and also say, it's okay. This is good conversation to have. It's okay to have. But I want to share that one time there was a hospital healthcare system that reached out to me and wanted me to talk to their team and their staff. And they said, you know what, we feel like maybe it's better if we have you talk to the first year, to the residents or those in med school, because once they've moved along in their career, they're set in their ways. Well, I was like, well, what are you talking about? Because then the ones set in their ways are the ones who are treating me. And so we can't go with that mindset, oh, they're set in their ways. Right. We're going to have you go come up with a workshop for the med school students because we can form them. No, we need to, because there are other physicians out there treating us. And while they're brilliant and many brilliant ones saved my life, there still needs to be training and education. And I love how Dr. Winkfield said that it was the cultural humility. And you have to build trust. And I'm sorry that I mentioned from the minute you walk in the door, part of my platform that I misspoke is that we need to prehab. My whole platform is about prehabbing and risk reducing long before patients walk in the door, build the trust. So when I hear companies allocating millions of dollars to diversity in clinical trials, that's important, but you got to build trust before they walk in the door. You want them to sign up. One negative experience and you've lost them.
Yes, absolutely. And Lorianna, let me just mention, when I was at Harvard, one of the things that we wanted to do was redesign the curriculum for medical students, right? And so that was the thing. Okay, we want to stop people thinking about race as an other, right? We want to stop people saying this is a 45-year-old black man with, right? No, what does that have to do with their disease? Like, what does it have to do with what their presenting symptoms are? It may have an impact on how, what you have to do culturally, right? But we said just that. It can't just be for the medical students. It can't be for the trainees. We need to retrain the faculty. So that's what we did. We actually designed a curriculum to help re-educate providers who had been in practice for a very long time. And that came out of the Disparity Solutions Center at Harvard at Mass General Hospital. And I tell you, there were people who were squirming. So Dr. Pazder, you're absolutely right. People were squirming in their seats. People didn't want to talk about Black, white, Hispanic. They didn't want to talk about LGBTQ+. But who cares? We need to. Like, what we've done is we've signed an oath that we're going to take care of people. And we need to take care of them equitably, not equally. So don't tell me you see everybody the same. Please don't. Don't say that. Because I need you to see me for who I am. And that's what equity is. Give me what I need. And the only way you're going to know what I need is to ask me.
Yeah, but it's almost like a continuing medical education thing. You know, physicians take continuing medical education to learn about new antibiotics, new molecular therapies, and societies has changed since many of these people have gone to medical school in the 1970s and 80s, and they have to realize that we're dealing with many new social constructs that have to be addressed in medicine, so to speak, and it's their obligation to do it. So that should be part of the continuing medical education, not only in the medical schools for new physicians, but I totally agree. But this is for people that have already preconceived ideas. It's one that you almost need more education and more permission, so to speak, that they have to discuss this, because I think that there definitely is a definite undercurrent of, oh, this is very uncomfortable for me to deal with, but it's not about you, it's about the patient, let's face it.
So that's part of the challenge that we see in our society now. We are so divided on everything, right? I mean, I think if you ask even oncologists, they're going to be on different sides of the aisles politically and from other different methods, right, or different measures. So this is where, if we really say, what is it that we're trying to do? Are we really trying to help people or not? You know, what are we trying to do? Because to your point, yes, there does need to be re-education, but I can tell you from being at ASCO and being a speaker that's sitting in a room that has over 2,000 seats and only the first 3 rows are filled up. You know why? Because the title of that session was about disparities, or the title of that was about social determinants of health. There are those people who just don't want to understand what the other side looks like, what it means to be from a lower socioeconomic status, like what does it mean to be from a disenfranchised community? They just don't want to know. And so this is where, you know, leveraging the capacity of organizations, sponsors, institutions, money, hate to say that, but look, this is financial. So we've got to leverage what we can to help move that needle. What can we do? What can the FDA do? What can sponsors do to say, no, we think it's important enough for you to be inclusive, not only in the way that you enroll in clinical trials, to Loriana's point, but inclusive in the way that you actually engage communities.
Mm-hmm. Amen.
From the patient perspective, that's really important. And it also goes to when you were talking about being preventive, not just waiting for a person, in this case, someone from the LGBTQ community or Latinx to be sick, it also goes when these treatments are designed. When you as an FDA go through the process on approving, evaluating the treatments or the medicines to be out there, it should be done thinking about the patient, not just by treating, if it's going to treat X disease or if it's going to reduce the amount of cells or something, is treating us as a patient. And when you take that route, you kind of move the curtain of who am I? You know, how does this patient look? I'm going to treat a human being, right? I want to prove something for the human being. So that's really important to also consider when you're doing the advocacy or your job as an approver or your job as a designer or an inventor of a treatment.
I'm going to give Dr. Pazder an opportunity to address how OCE is patient-centered in its innovative approach.
We have a lot going on, as far as I mentioned before, about our outreach programs here, and also in encouraging companies really to, and sponsors to have a diversity that represents the U.S. population in their studies. One of the things that we are seeing is offshoring of clinical trials. And this is, I think, a very negative thing for the U.S. because we really will not have a representative population. As more and more people are treated outside of the United States, we have fewer and fewer ethnic minorities that are represented here in the United States. But I think also is a cultural sensitivity about what we do in oncology. And I'd just like to share with you a story. We were talking with a rather contentious contentious meeting with one of the drug companies about a dose that they had proposed that caused, I think, a lot of toxicity for the benefit. Okay, a lot of nausea, vomiting, hair loss, you name it, diarrhea, low blood counts. And they said, oh, Dr. Pazdur, this is a tolerable therapy. This is oncology. This is a tolerable therapy. And I said, well, who told you it was tolerable? And they said, all of our investigators told us it was tolerable. And I said, well, what about the patients? Okay, well, we didn't ask any patients about this. The doctors told us this. And it clued into me also that there's a lot of cultural sensitivity as well as the issues with the gay and lesbian community and transgender community on what are specific toxicities that they are willing to take and the differential appreciation of those toxicities that we really have to realize, as well as efficacy goes. But I think how we even evaluate drugs need to be looked at. But this is an example, I think, that really resounded with me as far as, how focused on a number of people get and are not really seeing what they're doing to the patients. And here again, I think, and I'm sure you will all agree, there are very much cultural determinants on how people see toxicities and adverse events.
Yes, absolutely. And I'll second that. I co-authored an abstract on shared decision-making that was presented at ASH. And what we found, and even knowing personally as a patient, that what my oncologist perceived as a priority was different for me. Yes, I want to survive for my son, but they're like, oh, but you'll still be able to move and garden. Well, I want to do more than just go garden. I have a 9-year-old. So quality of life and understanding what quality of life means to each person. It's not like, oh, you know what? Yes, it has this long list and it's toxic, but you're going to live. If one more person tells me, well, be happy you're alive, well, I'm just going to just keep it to myself, but it drives me crazy. I want more than that.
Right. And this is why, Loriana, I say we want people to survive cancer, but to survive it well. And that's an individual discussion, right? So I've had conversations with patients who, could I irradiate them? Sure. But you know what? It's not going to do much but provide, more toxicity. And so they'd rather spend their last few weeks of life, whatever, spending time with their family. That's their decision. And it's funny that you bring up this abstract, because there actually was a great paper in LGBT Health that actually was around addressing barriers to shared decision-making among Latino LGBTQ plus patients, right? Like this is, I was shocked to find that, right? That something is that specific, but it's really critical because this intersectionality really kind of layers on kind of some of the challenges that there can be around that shared decision making. And I actually was interviewed for around LGBTQ youth. So can you imagine all of the stigma that there is, and yet these youth who may be diagnosed with cancer, young adults, adolescent young adults, and then having also to maybe come out to their parents for the first time. Like, there's all kinds of issues that we need to think about as providers, and to Olga's point, in the way that we design studies. But again, I think we've got to do our job with building that trust in these communities early, so that when people come through our doors, that we know that we're trusted individuals, institutions, providers.
One of the things that we're doing is, as you may know, the toxicity for many of the agents are graded by doctors and research nurses, and they're kind of referred information from the patient to somebody else and then recorded on paper. And what we're really trying to do is get the patient to really do this by patient-reported outcomes to assess the toxicities of the drug. I think that is so long overdue. It just is amazing to me that we just have assumed that, somebody else can describe a toxicity and put a number around it, so to speak. And we just add up these numbers, and that's the toxicity, and say, this is tolerable and manageable. And
right.
Those are two words that I wish were expunged from the oncology vocabulary: tolerable and manageable. And as I not jokingly said, but just off the said manageable. Everything is manageable. Even death is manageable. You just call the undertaker basically here. So like these terms have no meaning, yet they're always thrown around in oncology. It's tolerable. By whom? And who's making that decision? It's manageable. By like a 10-day hospitalization, that's manageable, but it's like nobody wants that, so to speak.
And Dr. Pazder, I think I love the patient-reported outcomes, and I remember kind of sitting down with y'all when I was an LDP fellow for ASCO, and you were talking about, you know, that's an important component of what the FDA really wants to push, right? But I think it's also important to make sure that we allow patients to describe what their toxicities are, because frankly, a lot of the standard stuff or language out there is not applicable to Black and brown people, especially in the radiation literature when it comes to skin, right? You think about from a radiation perspective, all of the things that describe skin are about erythema. Let me tell you, my Black and brown patients with radiation therapy, they oftentimes get brown, they get hyperpigmented. I've written lots of stuff and done some research on that. So I think part of it is really allowing people to describe in their own words. And I know that's harder, that's natural language processing, right? But that's what AI is. There are tons of grants out there, really allowing people for themselves to describe what they're going through and for them to measure and to allow them to say how impactful that is on their life.
And obviously the hair loss issue, alopecia, is a major issue too that has strong cultural implications.
So speaking of those cultural aspects, you know, I think in conversations like this, sometimes there's this inference about machismo and the cultural perspective of the Latinx community when it comes to physicians providing information, as if, you know, the doctor knows better than the patient. Olga, could you speak a little bit to that and some of your experience in regards to whether or not you ever felt hesitant and wanted to really just sort of, you know, depend on the physician to provide you the information as opposed to you're kind of an outgoing individual?
That definitely, you know, when you get that, once you pass and embrace the diagnosis, then it comes what comes next, and I mean, and you know, you've seen picture, you've heard people about what happens. So having that conversation with someone that makes you feel ease, at least some kind of ease, and that you can trust is very important. Like when it came down for my doctor to explain me what was going to happen during the chemotherapy process, that I was going to have the nausea, that I was going to go through the hair loss. Fortunately, in my case, it was it was a lobectomy. So I, you know, I didn't lose my breast. But I was concerned on how that is going to look like. What the scar what should I do next? And you feel fear to show yourself, right? You change your clothes, you change the way you interact with your partner, because you don't know what the reaction is gonna be. So having that. In my experience, he was very sensitive on it, and he went through the process. This is going to happen to you, but this happens next, and then you go through the process and you embrace. I mean, look at me now. I have almost no hair because I like the way I looked when I lost it. So now it's more as an homage to that you know, to growing through that challenge. But sometimes it doesn't happen. So then we as patients need to rely in other organizations seeking for that sensitivity, because you still want to live it, right? In essence, you want to live, and you want to live well. So if you don't find that in your physician, you go to other places. The thing is that it all depends where you go. So if we have centers like the OCE, it's good. We have trained people there with the heart in the right place. But sometimes you go to other places where they don't, and then the patients doesn't get that relief they need, and that happens with minority communities. And it happens, like, for example, within the LGBTQ community, where you don't have, I mean, we're talking about the intersections, right? So once you as a person have more of these characteristics, is the lower, the less places you have available to help you, because you don't have places with a lot of intersection to work together. So if you're Latinx and you're part of the community and that's your concern, you might not find a place where you can talk about the two things, and then you fall into other things, right? You're gonna try to look your east some other ways, and you lost people along that process, because they can't manage, they cannot find someone to relate to. So when we talk about helping these organizations, we need to think about that as well. We need more of those, because sometimes you just need to go outside your physicians to get for that help.
I wanted to jump in real quick and add on to what Dr. Wingfield, or actually ask you a question, Dr. Wingfield, and say, when you mentioned about that room that you were speaking and only the front row to talk about health disparities was filled, do you think that there are actually some physicians and those in the healthcare who may think, hey, I already know this. I already feel like I treat my patients fair, and I'm well-versed in to understand and not make assumptions, so they think they don't need the training? And then you have the other component that maybe you hear those in the healthcare system saying, well, we're so busy, we're doing more with less, we don't have time for the training, we get it.
Yeah, I mean, it could be all of those things, but I tell you, the NCCN did a survey of providers, of oncologists, and asked them specifically about what their knowledge base of disparities are, and they clearly are deficient. So, you know, I mean, they are admitting that they don't know, but maybe it is the kind of how thin all of us are spread. But this is why the importance of teams, right? So you've heard me emphasize, look, I'm a radiation oncologist. I could not treat my patients without my team members. Like, I need my nurse, I need my therapist. I don't believe that it's just me, right? None of us can. And so how are you building your team? And what infrastructure are you putting in your team to kind of help with that? But I still think we need to understand the importance of social determinants of health. We know that more than 75% of an individual's health and well-being, of population health, happens outside of the healthcare system. So if we don't know that as clinicians, if that's not being taught in medical schools, if that's not being re-educated in CMEs with our folks who've been in practice for a long time, we are just going downhill. Look, we're going to go downhill quickly, because we need to understand that social context impacts and influences outcomes more than biology, more than genetics, more than treatment. Because frankly, and I'm saying from my experience, look, my daughter is lesbian, and I can tell you as a Black, lesbian woman, the challenges that she goes through with just accessing healthcare, right? We see it across the board in cancer care. Black women, Hispanic women and men, LGBTQ+, we can't even get in the door to have some of these conversations. And this is why the social determinants of health are important. So again, I think it's a very complex reason why people don't, but I can tell you, I've been doing this work for decades, and the room is always empty, until now.
Mark, did you want to weigh in on that at all?
Until now, that's the key word. And it's sad that it's until now. It should have been happening a long time ago, but I'm glad we're having the discussion now. We'll still take it.
I do have a question, and we've been talking about providers and mainly thinking about the doctors, right, that provides the treatment. But I'm curious about the work being done with health insurance providers that are in the middle of that equation as well. We have patients, we have the doctors, but we do have a health insurance provider also, and how have you worked with them, and how do they have a role in this picture of improving accessibility to these communities?
I can't speak to the health insurance providers, but I mean, certainly access to care is a hugely important component of the health disparities. And we see that. I mean, when you think of not having health insurance, delaying care because you haven't had a checkup in the last year, or avoiding care because of costs, or not having a dedicated physician or a primary care physician. All of those things really are concentrated in the Latinx community and in the sexual and gender minority community too. And the biggest disparities, if you look at the research, show between heterosexual or even of other races and ethnicities, that those things are a bigger factor for that community. A bigger structural issue and more difficult to overcome, but we certainly see that as a contributor to those disparities.
Yeah, Olga, I was going to say that certainly everything that Mark said, I'm going to echo that, because we know that individuals from the Hispanic community tend to be, have less insurance or be more frequently uninsured. Same thing with LGBTQ plus community, so you combine. But this is where what Loriana said makes so much sense. Don't make an assumption. I was on a call yesterday with somebody, Black woman, professional, with her doctor, and said, "Can I see your Medicaid card?" Like, what? Like, so you're going to make an assumption because there's a Black woman that's standing in front of you that they're on Medicaid? Like, what? So these things happen all the time. So, Olga, I think the challenge is when we have individuals who are undocumented. That's where particularly my work in North Carolina, I can tell you what we're doing is we actually work, when I was in Boston, I worked with the Latino Health Insurance Program, so LHIP, and what they do is they actually try to provide access for insurance, specifically to Hispanic populations, but they actually open up to anybody, and so they have resourcing there that helps people identify what insurance products they are eligible for. Remember, Massachusetts had Romney Care before there was Obamacare, right? So they had like universal coverage. So sometimes it's just about the information, and again, this is where we could be trusted partners. Institutions, individuals can be trusted partners with helping communities identify what insurance products they may be eligible for.
I just want to go back to a couple points that to follow up on from earlier. We haven't talked a lot about our trans community members, and I think that when it comes to oncology, there's just so much information that we don't know and that providers don't know. And I don't have the citation in front of me, but there was a study of specifically of oncologists that asked about their levels of knowledge and comfort in treating trans patients, and significantly low. These providers did state that they wanted that education, but it is lacking. And going back to this idea of shared decision making, I think when it comes to queer communities, there's just so many assumptions that are made around whether or not someone wants reconstructive surgery, if they have breast or chest cancer, whether or not folks want to talk about preserving fertility. And then for trans and non-binary folks, if they're on hormones, what does it look like? What does their treatment look like? Are they able to continue those hormones? Do they need to discontinue? And when Dr. Wingfield talks about living well, I think that too often the conversation is around keeping you alive. And for folks that are that have other considerations, that's just not enough.
Well, it's not a binary also of being alive or not being alive. Okay, there are therapies that you could have a discussion about, that these are the toxicities of these therapies, these are the toxicities of these therapies. So let's talk about this, so to speak, what meets your needs. I think in that conversation doesn't generally occur because many oncologists have one thing on the mind, a survival curve, basically, and a median survival.
Yeah.
Which isn't like a binary, you don't live or die. It's just you may have a less chance of living, but you have less toxicity. What would you want?
Yeah. So Dr. Pazder, your point is well taken. And I think this is where rethinking how we educate our oncologists is important, because frankly, that is the discussion sometimes amongst, cisgendered white men, right? It's just about, all right, here are your treatment options and here's the percentages, right? From a lot of our oncologists, it's about, what the treatment algorithm is going to be, and less conversation about what are the patient's goals. And that conversation is happening. So what I want to say is, I don't want the Latino, Latinx, I don't know, whichever kind of version of that you want to use, LGBTQ plus community to think that this is specific to them. This is a global issue of providers learning how to really have that humility and see the person in front of them and ask the questions. Again, this is where your care teams come in. And I'm very blessed as a radiation oncologist. I can say, give me, an hour with a new patient. That's not the case for a lot of folks. They're like, it's sometimes ridiculous. And so I think that's important. Let me just go back to what Michelle had said too about transgender. what's fascinating is that, so once a provider gets labeled as someone who's friendly and who understands the community, people will show up. They really will. And I think that it's really important. And so one of the things that I worked with at Case Western, I'm not sure if you knew this, Michelle, but they actually have an LGBT center at Case Western. And so I was one of their speakers a couple of years ago to their community. And we talked a lot about transgendered and the ways that we can support the transgendered community. Because look, it's really hard, you know, if you're not out or people don't know that you're transgendered, you know, how do you even start the conversation? But that's the center. I just want to make sure that, again, we're talking about solutions. We're talking about who's doing the work. So I want to make sure that the LGBT Center at Case Western, I highlight the work that they're doing there, because what they're trying to do is create networks. And I know that actually, I know your center also does this too, your group, where you say, who are the LGBT friendly, you know, providers? And I think that's an important thing, again, that institutions, communities, individuals can do. And part of it is what shows up in your practice, you know, what shows up, you know, if you're a sponsor, what does your material look like? Are you inclusive in the way that you're representing the patients that you're hoping to include in your trials or that you're trying to treat? Making sure that, you know, what people see is really what you want them to see. Right? You want to be inclusive. Make sure that you're including individuals who really represent the different types of communities that we serve.
One of the things that we have not talked about that I think is very important in this intersection between these two groups is the words La Familia and the family and its role. And this is different, obviously, in the LGBTQ community versus that's Hispanic versus potentially the kind of general Hispanic community. And I'd like to hear your thoughts on this, because many times, especially gay youth are ostracized from their families. Many times they never mend those relationships. And this is particularly true in the Hispanic community, not unique necessarily to this, certainly not unique to the Hispanic community, but family plays such an inherent role in people that are dealing with cancer, but particularly in the Hispanic community. And then when you have people ostracized from their families or not part of that family, or have created a new nuclear family sometimes that is outside of the traditional nuclear families. Anyone want to comment on that?
Sure. I mean, that is something that we've seen in actual practice a lot, and being able to see differences in different locations too. As I mentioned, I'm in Miami, and a lot of our studies will be done here in South Florida and in New York and or Boston. So we get to see the role of family and the individual experiences of mostly sexual and gender minority participants and how it's different by site. Here we have a lot of people who are, I mean, Miami is about 70% Latinx, and a lot of our residents are foreign-born too. And we may be coming from places that are less accepting of gay and bi and lesbian children. And so we do see a lot more here, people who have had that disruption in their family and may be kicked out or maybe in the closet and not feel comfortable talking to their family. And it's starkly different in, you know, maybe more cosmopolitan places like Boston or New York. And it really gets in the way of their treatment and their care, and the mental health treatment too. It's a big issue to overcome. And so the family involvement is a bit of a double-edged sword in some ways, because it can be very protective. And I think as a traditional Latinx cultural value, it's very beneficial in a lot of ways. And then on the other side of it, it can also be a bit of a hurdle.
And I think it's so disheartening. I mean, I am not part of not a member of the LGBTQ community, but going through as a two-time cancer survivor, family, and I call it a pit crew. I needed hundreds of people. And fortunately, I was on the air and a news anchor. So many people were able to come to my aid and fill the voids. And I always said, how would somebody who didn't have this many, how do people get through this? And I remember that going into survivorship after spending a year in the hospital, one of the friends I made with a cancer patient, his name is Armando, and he is part of that community. And he would be on the phone while we were waiting for infusions. And he'd say, oh, I'm at an offsite meeting today. And I'm thinking, you're having an infusion going through your arm. And I would just cry thinking, that you have to hide behind this diagnosis that you need so many people to help you get through, and actually say you're at an offsite meeting. And to know that there's that stigma, it breaks my heart, because more than ever, when you're in the underserved community, you need help.
When I practiced at MD Anderson, we obviously in Houston has a huge Mexican population, Hispanic population, and it was like toda la familia están aquí, and everyone was there. We had to have 2 exam rooms basically, and it was very interesting to see the dynamics of this person, that person, who was the decision maker, and coming to kind of a unified decision. And I regretted in treating and others that did not have that family because of their sexual orientation, and that were ostracized from their family, not to have that support. And I realized that they had been part of that community at one time. And it was sad to see that, but many times people form new relationships also, and new nuclear families that I think we should also be aware of.
That is just why it's so important what we're seeing now with this type of centers where you have the therapy is integrated. It's not only the radiation or the chemotherapy. You also have group of psychologists, even alternative medicine integrated into the whole healing experience, because although it doesn't make up for the emotional part that you feel having your support group with you, you have some kind of support that otherwise you will be missing as well. And hopefully that allows this type of people to be in a very good place enough to build new relationships with the people they meet there and start building that support group for what's coming after your treatment. So it's something that I'm 15 years survivor, and it wasn't there 15 years ago, or maybe it was in the beginnings or isolated. You see that more and more now. So I'm all up for that to continue happening, and mainly the integration of traditional medicine with the alternative medicine, coming into that understanding to have a better proposal for healing for a patient.
And psycho-oncology is fortunately an emerging field. The problem is, so we're acknowledging that yes, psycho-oncology is important. We need it, especially for the underserved communities and anybody going through cancer. Problem is, when you realize, hey, I need help, trying to get help. And even myself, 2 weeks ago, I'm still trying to find a therapist in the Atlanta area where I moved. They said they only take cash. And I asked, are you a cancer-related PTSD therapist? No, it's only, I am, but I take cash. So I'm thinking, how can we fix this? I know, Dr. Wingfield, you say you're solutions-oriented. I am too, but maybe you have with your new role, how can we fix this and give access to psycho-oncology and the social help that we need? Because I keep saying, as patients, when we are mentally in the game, we're there longer to enjoy the benefits of the new innovations that the FDA is approving. And it's a win-win for everyone, but our mind's got to be in it. And we need someone to help us keep our mind there.
So I'm just going to interject here, just so you know, panelists, this is probably going to be our last exchange, Dr. Wingfield. So you're basically getting the last word in regards to solutions and so forth. And then we'll go to Dr. Pazder for concluding comments. So you have the floor, ma'am.
Great, thank you so much. Well, listen, I tell you, there's so much that needs to be done, but especially around mental health, right? So again, when you have intersectionality, there's often so many pressures, microaggressions, macroaggressions, things that people are dealing with, that when I see a patient who comes to me, I try to address them holistically, and that includes mental health. And let me tell you, there are resources that are available that actually are available virtually. Here's the challenge, and we're learning this with telemedicine now, right? Great opportunities, especially for people. We know there's a digital divide, number one, but number two, we also have to deal with the insurance problem. And this is where, again, Olga, you talked about insurance. We need to figure out how we can do insurance across states, because not only do you want a provider who can understand what your situation is and help you with your current situation, but you also want somebody who's culturally sensitive, right? Who has some cultural appropriateness. And so that can be even more challenging to find in a location. So I think we need to work on that from the insurance space. And so I do think that there are a lot of great things. Look, there are barriers to this community. Just for folks who might be listening, think about the fact that we know that Latinos and Hispanics already are underserved in so many issues related to health. LGBTQ+, one of the most underserved communities in cancer. Intersectionality, we still have a lot of data collection to do. Thank you to the LGBT Center for doing this work. And we've got to figure out what the data is, but that starts with us in the healthcare system. Us, those of us who are part of the system, we need to work together towards solutions.
Dr. Pazder, final words. You look pensive.
Oh, I want to thank everybody for attending. I was thinking when we had this discussion 10 years ago, we would never have even thought of having this discussion. Probably 5 years ago, we would not have even had this discussion. Probably 2 years ago, we might have had this discussion, but probably might not have had this discussion. So I think that this is an important conversation, and I look forward to meeting you all on different platforms and continuing this discussion as we move forward in our conversations on cancer. And I found this just a fascinating concept to look at the intersection of really two communities here. So I really appreciate all of the people that were involved in this panel, and hope that the people that the people that have listened to this have benefited from this and will take lessons from this into their own life, basically. Thank you very much.
Thank you all, panelists. Really appreciate you and your comments. Thank you to the audience for joining us today. And just encourage everybody, if you haven't thought about it, please do consider participating in a cancer clinical trial to help advance the science that takes place at the Food and Drug Administration, and specifically in the Oncology Center of Excellence, where we are patient-centered. Thank you for joining us today. Have a great day. Bye-bye.
Bye.
Thank you.